meeting is being recorded.
Good evening. We are going to just give a couple of more minutes for everyone to join in. Just give it one more minute and then we'll get started. All right, so I think in the interest of time, we're going to go ahead and get started with today's grand round, which is going to be the second half of our ACC presentation wrap-up. And for today, we have three presenters. We have Dr. Saba Bhati, Dr. Janet Kai, and also we will have Dr. Abdul Hakim, who will be joining in hopefully soon. He is probably scrubbed in a case and we're going to wait. But the order in which we will do is we'll have Dr. Bhati and then we'll have Dr. Kai, and hopefully we'll have Dr. Hakim joining in. So we all know Dr. Bhati very well. She's Associate Professor of Medicine and the Director of the Non-Invasive Lab at the Rutgers Robert Wood Johnson Medical School and the University Hospital. She is previously done her imaging fellowship from Henry Ford Hospital and subsequently had a faculty position at UAMS, and that is University of Arkansas Medical School. And she is very well known for her academic work here with over 50 publications, and she has contributed enormously and single-handedly to the imaging program, particularly the Echo Lab. And for the last 3 and 4 years, I always tell her and thank her for her steadfast attributes in bringing in the quality of the program and making the program so far very important contributor to the growth of the school and the university. The cardiology, ultrasound laboratory, both in the inpatient and outpatient, have excellent imaging quality. And I think she has been responsible for maintaining a very high quality of the echo program here. So thank you for that, Saba. With those notes, I think I will have you present to us your insights on what you found interesting in imaging at the ACC, and then we'll move on with Janet. Saba.
Thank you, Dr. Sengupta. I'm going to try to share my screen. Do you see my first slide?
Yes, we do.
Okay. So good evening, everybody, and thank you for this invitation to highlight some of the trials that were presented at ACC. Since Navina said 3 people were presenting, I've limited myself to about 10 minutes. And I went ahead and I selected these 3 trials to talk about. So these are non-interventional trials that I felt will actually change management. So the first one is the Poise III, the second one is the CHAP trial, and then the Velar HCM trial. So the first trial we want to talk about is the Poise III trial. This is the effects of a hypotension avoidance strategy versus a hypertension avoidance strategy in patients undergoing non-cardiac surgery, essentially the Poise III trial. Basically, what this long title means is they wanted to assess whether it was, worse off for patients to be hypertensive, since what people tend to do before surgery is hold the antihypertensives with the fear that the kidney function is going to get worse or the patients are going to get hypotensive. So again, the purpose was to determine peri-op hypotension avoidance strategy versus hypertension avoidance strategy and the 30-day incidence of major vascular complications. The study design was a multi-center international non-inferiority randomized control trial with a 2x2 factorial design. They enrolled about 7,490 patients at 110 centers in 22 countries. So quite a robust patient population to look at this clinical question. The primary endpoints, major vascular complication, was a composite of vascular death and non-fatal MI after non-cardiac surgery, stroke, and cardiac arrest at 30 days after randomization. The secondary endpoints were myocardial injury after non-cardiac surgery, so kind of mild troponin leaks, what we call MI, stroke, vascular mortality, or all-cause mortality. So here on the right side, you can see that for the most part, they found that there was no difference in major vascular complications for the hypotension avoidance versus the hypertension avoidance group. Interestingly, none of the secondary outcomes were significant either. And so the takeaways for the clinician from this are that target mean arterial pressures greater than 60 or greater than or equal than 80 produce similar vascular outcomes. Perioperatively holding ACE and ARB and continuing chronic antihypertensive medications based on blood pressure versus continuing all antihypertensive medications resulted in no substantial impact on hemodynamics and vascular outcomes. So again, hypotension versus peri-op hypertension had no incidence on 30-day major vascular complications. So we'll talk about it more when Dr. Sengupta opens up discussion, but this is an important trial because this question often comes up as to what to hold prior to non-cardiac surgeries. The second study that I thought was interesting and important and will lead to changes in management is the CHAP trial. So for those who haven't heard of it, this is antihypertensive therapy for mild chronic hypertension, improves pregnancy outcomes, a pragmatic multi-center randomized control trial. So the question here is really that the American College of Gynecology actually recommends treatment of hypertension only when blood pressure is severe. And what this group of investigators wanted to look at was whether a BP strategy during pregnancy to achieve targets that are recommended for non-pregnant patients, which is less than 140/90, compared to what the American College of Gynecology recommends, is effective and safe. One of the concerns out there is that there is premature labor and intrauterine growth delays in the fetus. And this is why they have a higher blood pressure cutoff for which they treat patients. So the trial design was open label, multi-center randomized control trial with parallel assignment. And this was performed in 2,408 patients in 61 sites. Basically 1,208 patients in the treatment arm and 1,200 patients in the no treatment arm. The primary endpoints were a composite of preeclampsia with severe features, preterm birth less than 35 weeks, abruption and neonatal fetal death. The safety outcome was small for gestational age, so SGA birth weight less than 10 percentile. The secondary endpoints were preterm birth less than 37 weeks and preeclampsia. So here's a table on the right side. So this had some interesting findings. So in the intervention arm, which is essentially the arm that was started on therapy when their blood pressure was above 140/90, there was an improvement seen in preeclampsia, as well as they were less likely to, they actually did not see that the patients were born premature or had low birth weight. So they said that the primary outcome incidence was lower in the treatment group, SGA less than 10th and less than 5th percentile was similar in both groups. So less preeclampsia, and the babies were not born at a smaller birth weight. So this was a favorable trial for treating patients early at a blood pressure of 140/90, as compared to what is currently done, which is a higher blood pressure or a severe blood pressure is how they've called it. So the third, and I think actually one of the most interesting and exciting trials that came out of ACC this year is the trial on Mevacampton. So for those who haven't heard of it, I've included this slide. This is from ACC 2021 when the first trial was done and the drug was introduced. Essentially, Mevacampton is a target inhibitor of cardiac myosin that reduces the number of actin-myosin cross bridges. So up here is a normal sarcomere, and we can see here that there's an actin-myosin cross bridge and there's normal contractility. So what happens in hypertrophic cardiomyopathy is that there are a lot more of these bridges, and there's hypercontractility, impaired relaxation, and altered myocardial energetics. Mevacampton, by mechanism of action, which is targeted inhibitor of cardiac myosin, decreases these bridges and hence leads to attenuated hypercontractility, improved compliance, and improved energetics. So this is a really exciting drug out there because it's able to do it's able to cause this mechanism of action in hypertrophic cardiomyopathies, which is something that was not an option in these patients prior to this medication. So the Velar HCM trial was presented at ACC, and this was Mevacampton significantly reduces need for surgical intervention in patients with obstructive hypertrophic cardiomyopathy. The trial was a randomized, double-blind, placebo-controlled trial. It evaluated the use of Mevacampton in a total of 112 adults with symptomatic obstructive hypertrophic cardiomyopathy who were referred to a hypertrophic cardiomyopathy expert at 19 centers, and these were expert centers. All patients had documented hypertrophic cardiomyopathy with maximum septal wall thickness of greater than 15 millimeters, or greater than 13 millimeters if they had a family history of hypertrophic cardiomyopathy. They also had severe symptoms despite maximally tolerated medical therapy, which included beta blockers, disopyramide, and any calcium channel blockers. They had dynamic left ventricular outflow tract gradient at rest or provocation of greater than 50 millimeters of mercury, and a documented normal left ventricular ejection fraction greater than 60%. So the researchers randomly assigned each patient to receive Mevacampton or placebo for 16 weeks. And the primary endpoint was a composite of a patient decision to proceed with surgical reduction, with septal reduction therapy, or continue to meet the 2011 ACC/HA guidelines eligibility for septal reduction therapy after 16 weeks. So we know that septal reduction therapies include alcohol septal ablation and surgical myomectomy. So interestingly, at 14 weeks, only 18% of the patients on Mevacampton were still eligible for septal reduction therapy, compared with 77% of those on placebo. So the researchers also observed significant improvements across all secondary endpoints, including reduction in resting LVOT gradient, greater than 1 class improvement in New York Heart Association class, and improvement in their Kansas score clinical summary score, reduction in their N-terminal pro-BNP levels, and reduction in their troponin levels. And they also noted that no patients basically developed any major side effects. I think one of the most common side effects noted was nausea. So this is an extremely interesting and exciting trial, because we, as those of us who take care of these patients, know that there are not many options that are non-invasive, and as far as the invasive options go, it's extremely important for patients to be done at centers that do a minimum number of cases per year in order for them to have good outcomes after alcohol or surgical myomectomy. And so the drug is under FDA consideration, and I think they're going to announce at the end of April if this is going to be clinically available. So I'm going to stop sharing my slides. Those are the 3 trials.
Thank you, Saba. I think, and we are open for a Q&A session. I think we can have people type their questions in the chat box. I'm going to start with some comments. Obviously, the third one was the most exciting one, and I would like to just pass a few comments and then have you reflect back on some of the questions I have. First of all, hypertrophic cardiomyopathy and contractility. I find that very interesting because when you do strain analysis in patients with hypertrophic cardiomyopathy, and it's very well established that strain is a deformation parameter. And what you find is that there is a paradoxical finding that you will see that the longitudinal contraction of the deformation of the heart will be reduced more so in the areas where the hypertrophy is present, and the global longitudinal strain is global contractility in the longitudinal direction is also attenuated. However, paradoxically, the EF is always normal. Mm-hmm. So I was intrigued when they started by stating that contractility is increased in hypertrophic cardiomyopathy, and we want to bring it down. Now, I would like to also mention at the same time that the long axis contractility is also afterload dependent. So if you have a high gradient, obviously the LV is not going to contract. So having said some of this pathophysiology and observation from the past, I find it really interesting that perhaps by eliminating the radial forces, which is increased in hypertrophic cardiomyopathy because the chamber is small, and eliminating the gradient, you may have improved the function of the heart. And post-septal reduction therapy, we do see that there is improvement in the function. So I would have just wondered if they are going to show us also some of the echocardiographic findings, but I find it fascinating that what you're seeing is a unique pathophysiology of a very interesting disease getting altered with the drug.
Yeah, I think I echo your thoughts. I think it's very going to be very interesting to see what it does to cardiac output at the same time as what's going on with the strain, as you mentioned, and that's probably going to be in some of the subsequent publications. But this is one of the groundbreaking trials because many times patients are started on a beta blocker, calcium channel blocker, disopyramide, and people are not necessarily at centers where this is, and not everybody's a candidate for it. Sometimes they don't have that one big septal perforator that you can go after, and they're not a surgical candidate. So it's going to be interesting. The other thought I had was, I'm not sure how you can necessarily control how much of that decrease on contractility there's going to be. So how many of these patients potentially might have a drop in ejection fraction or drop in contractility greater than what we aim for, similar to what happens when we do an alcohol septal ablation. Sometimes the area that you create the infarct in is much larger than what you wanted to do.
Yeah, and Sabah, one more thing I wanted to ask is, it will be also interesting to see if they have some form of regression of hypertrophy, right? Because hypertrophic cardiomyopathy, when you do the septal reduction, there is some data that you see more stabilization and reduction in the LV wall hypertrophy, progression of the hypertrophy, and LV function tends to improve. So it will be interesting to see that, and maybe future we'll have to see MR studies, because ultimately hypertrophy, the risk of sudden cardiac death, scarring, myocardial scar, and all those things will be very interesting to see the whole natural history of how it gets altered. Obviously, the presence of obstruction is a major determinant of exercise limitation. But independent of that, there are myocardial viscerae and scar, which independently cause development of cardiac arrhythmias and sudden cardiac death. So it'll be interesting to see what all other features come into play in the natural history and whether they will be corrected. So very interesting. And any other thoughts, any other question? I don't see any other questions as yet. So your other two trials, the pregnancy induced hypertension, I was very pleasantly surprised that they went in a good aggressive approach and didn't see any placental insufficiency, because that has been in the past a concern. And as you mentioned, that IUGR or fetal insufficiency was not observed. So do you think that's going to make a change in how we take care of the pregnant patients? At least I have not visited the guidelines recently.
Yeah, I mean, I think that's why it was an exciting trial, because it will take some time for it to be reflected in the ACOG guidelines, the American College of Gynecology. But for now, at least from a cardiac standpoint, when we get consulted on these patients, we can definitely quote this trial and say, based on the literature we have, there's not been any harm as far as maternal harm, but also there's been no evidence of IUGR, so we can safely decrease their blood pressure.
Very good. Thank you, Saba. I think we'll move on to, I think Dr. Hakim has joined. Abdul Hakim, if I'm, I believe. Thank you, Abdul, for joining in. So Dr. Abdul Hakim is the director of the Cardiac Interventional Fellowship Program at Robert Wood Johnson Medical School and University Hospital. He's associate professor of medicine. Previous to coming here, he was chief of cardiology at University of Arkansas. And his reputation for being a reliable clinician, interventionist, and structural cardiologist, and colleague and friend has grown over the several years, and we've been very fortunate to have him with us. And I also really see that he has been very prolific in his scholarly activity, with over 130-40 publications to his credit, and he has also groomed a lot many people to have scholarly contributions. So thank you for your mentorship and for your collegiality and taking us with you on your work every day with great humility and passion. Thank you for being that. So Abdul is going to give his presentation. He was an invited speaker, and we are eager to see what he has to contribute to ACC. Abdul.
Thank you for the kind words, Dr. Sengupta. So let me share my screen, and hopefully I am going to share with you. Okay. You're still seeing my face. You're not seeing my slides, huh?
We're able to see it now.
You're able to see my slide now?
Yeah, we were able. We were just now, a little time back. You can try it one more time.
How about now?
Yes, now. And you can go to this, yes.
Okay, you can see them now?
Yes, if you could just change your display setting on the upper left top. If you see the display setting, click on that, on the next one next to that. Yes, and click on that and swap the presenter slide. Yeah, click that. Perfect. Now you're good to go.
All right, great. Okay, so because I have done some work in the field of post-interventional physiology, most of it during my time at my previous institution in Little Rock. We published some groundbreaking work, and based on that, there's a field that has been long thought of, and it gave it more credibility. I'm going to share some of the work. And so over the past couple of years, we have published some really solid findings that will hopefully change the way we approach the results of percutaneous coronary interventions. So the topic of my talk at ACC this year was post-intervention FFR is critical but underutilized. Is AngioFFR the answer? So unfortunately, there are no disclosures for me. In way of background, we all know that the goal of revascularization, either by surgical or percutaneous means, is to restore adequate tissue level blood flow to meet the metabolic needs of the ischemic myocardium. And we have shown, along with other groups, that in contemporary practice, when using pre and post PCI physiology, with modern generation state-of-the-art stenting techniques, up to 36% of vessels would demonstrate functional ischemia by either FFR of less than 0.80 or one of the NHPRs, despite having an angiographically successful stenting result. And this disconnect between what is believed to be a successful PCI intended to reduce ischemia and a significant proportion of patients who leave the procedure with ischemia then underscores the need for a more precise approach to PCI. I'm not sure how many of you are familiar with this picture, but this is the first angioplasty performed in man by Dr. Grunzik. And that was a proximal LAD lesion. And when the lesion was crossed with the balloon catheter, there was a significant gradient that was demonstrated. Dilation of the stenosis was done, and normalization of that gradient was demonstrated. So the very first PCI was done, and the arbiter of success was elimination of resting gradient that was demonstrated. So this is that prox LAD lesion that was treated by Dr. Grunzik in 1977. And then 23 years later, the patient presented with some atypical chest pain, was cath by Bernard Meyer in Switzerland. And you can see that the result of plain angioplasty was significantly robust. So then over time, physiological assessment of PCI results was lost. I don't know why. Now we know that post-PCI FFR, this is the result of a study that has been accepted in JAMA Cardiology, and it's a collaboration between our group and multiple others. We know that there's a very few proportion of patients who would actually achieve a post-PCI FFR of more than 0.90, which is considered ideal. And in this patient level analysis of over 5,000 individuals, less than 11%, more than 11% of patients actually had ischemia when PCI was completed. And there was a very strong correlation between the post-PCI FFR result and target vessel failure, which is a composite of cardiac death, myocardial infarction, or target vessel revascularization. And there was a strong association not only with target vessel revascularization, but the individual endpoints of cardiac death as well as MI. So this has also been demonstrated more recently with non-hyperemic pressure ratios by Dr. Manish Patel from Duke as part of the DEFINE study, where they showed that IFR of more than 0.95 had significantly lower MACE event rates compared to those with an IFR of less than 0.90. Our group also demonstrated that just using the more simple tool, PDPA, which is available on all platforms, provides very strong discrimination in terms of future prediction of not only MACE, but also target vessel failure. Now, despite the fact that there is such strong evidence over the past several decades that post-PCI physiology is strongly predictive of long-term outcomes, why is it not routinely used as an arbiter or as a corroborative standard of PCI success? There are multiple reasons for that. Number one, there is lack of established clinical benefit in a randomized controlled trial. We do not know, although we do know that a lower FFR post-PCI is associated with a high risk of MACE. We do not know that efforts made towards increasing that final value will actually improve clinical outcomes. Obviously, there's increased costs of giving adenosine using a specialized FFR wire, and you increase procedure time, which is why it is less attractive to many operators. And obviously, a small proportion of patients will have adenosine-related side effects. Now, there have been debates going on about the adoption of FFR. This is a study we published about 6 years ago looking at the adoption of FFR in the United States, and between 5 years, we saw a significant decrease in the number of PCIs, and part of it was an increased adoption, almost a five-fold increase in the use of FFR and FFR-guided PCI. And this trend has been also noticed over the past 15 to 20 years globally, where anywhere between 2 to 100-fold increase has been noticed in the adoption of physiology towards evaluation of CAD in the cardiac cath lab. What about post-PCI physiology? This is a fairly recent study and a multi-center study from Italy, and the appropriate use of FFR based on European guidelines, where it was a class 1 indication back then, more recently has been a class 1 indication in the updated US guidelines. 48% of cases that were done used FFR appropriately. And of the number of PCIs that were done using FFR guidance, only 9.4% actually repeated FFR to confirm that the ischemia was gotten rid of, despite the fact that all those cases were done demonstrating ischemia on FFR pre-PCI. So this brings us to the concept of AngioFFR or QFR, or different terms that are used for it. This is an angiographically derived estimate of FFR, and it has to do with computational fluid dynamics, and there are different explanations for how it works, but the bottom line is it has shown very strong correlation with invasive FFR, actually much better, in the order of 90 to 95% in comparison to FFR compared to the NHPRs. Different platforms are available. The only limitation currently is that it cannot be done real time. You have to do two angiographic views, make sure there is no overlap, have to be at least 20 degrees apart. There's got to be good contact injection, and obviously it's not good for osteal lesions or bifurcation lesions and very distal lesions. And the major limitation, like I said, is it's an offline analysis, but if it can be performed in real time, it may become an important tool to optimize interventions. And I've already told you the limitations of that. So although multiple studies, actually 2 randomized trials, have shown the utility of QFR or angio-based FFR in improving outcomes, there have been 2 recent studies, one by our very good friend Simone Biscaglia from Italy, that we have collaborated on multiple trials with, who looked at the role of post-PCI QFR and patients, about 600 patients undergoing PCI in 2 centers, in 2 countries, in Italy and Spain, and found a very strong correlation between post-PCI QFR and on ROC analysis. They identified a threshold of 0.89, which is very much similar to the threshold of IFR and RFR and other variables that we use. And that threshold post-PCI was found to be strongly correlative of heart events at 3 years follow-up. And on Cox proportional analysis, they found a post-PCI QFR as a continuous variable to be a very strong predictor of outcomes. So how that works is there are different beautiful iterations of it. If the artery has normal flow, it's color-coded blue, and if it's in the intermediate area, it turns green, and red really means that that segment is ischemic. So you can see that pre-PCI, if done properly, and where it has really been validated, you get a really nice map of what segment of the artery is ischemic. And after you put a stent in, you demonstrate flow getting normalized, although it is derived from angiography itself. There's another study from the Syntax-2 investigators who did a post-op analysis using QFR, and they also showed a slightly different threshold, post-PCI QFR of 0.91 as being the best discriminatory point of predicting events both at patient level and vessel level. And this persisted despite the use of IVUS guidance, although without the use of IVUS guidance, post-PCI QFR had a better discrimination. It remained significant even with the use of IVUS guidance. Now, I have explained to you that higher flow post-PCI is better. Post-PCI FFR of 0.95 is better than 0.92, is better than 0.89, is better than 0.80, is better than 0.75. And we know that less than 0.80, which is really ischemia, would persist in up to a third of patients despite having a beautiful angiographic result. And why is that? And we've looked into that and studied it very carefully. And here I'm sharing the summary. It is either there is geographic miss of the culprit lesion. The lesion may be at a bend, and what you see as being the lesion may not really be the lesion itself, or you did not cover the lesion from healthy to healthy segment, or there is a stent issue where the stent may be undersized, underexpanded, and most commonly, in about 35 to 40% of the patient, is diffuse distal disease, most commonly in the LAD. There may be a hidden edge dissection, or there may be serial stenosis, where if you fix the most severe one, the less intermediate stenosis becomes hemodynamically manifest after treating the more severe one. Could be coronary spasm, extreme vessel tortuosity causing wire bias or the accordion effect. And then in certain cases, if there is a large CTO segment supplied by an intermediate lesion, that may give you a persistent ischemic FFR, myocardial bridging, and then obviously technical factors. So can post-PCI FFR, if it is suboptimal, be improved? We have shown that, and this study is now almost 6 to 7 years old in about 600 individuals, where a quarter of patients, after having had angiographically sound PCI results, still had persistent ischemia. And then using a combination of IVUS, additional stenting, post-dilation, the overall hemodynamic outcome of these patients was significantly improved. That translated into improved clinical outcomes. So now we have shown that ischemia post-PCI is predictive of events, and we have also shown that if you are to detect persistent ischemia, and then you to undertake further measures while the patient is still on the cath lab, you can improve the overall hemodynamic outcome of the procedure, which then could improve your outcomes. Now, this is a very important slide, and I think this is something we really, really need to understand very well. Now, for a patient who gets a PCI in the cath lab, the future risk is contingent on multiple factors. Of these, the most important is the patient's clinical risk. The patient either presenting as stable patient or as ACS, the patient who has diabetes, CKD, advanced age, etc. And then the angiographic burden of disease increases risk prediction. And when you add physiological information to that, you can indeed improve further risk discrimination for these patients. Now, having understood that concept, what is then the holy grail of physiologically guided PCI? The important question is, does optimizing post-PCI FFR to the highest possible threshold, whether it be by NHPRs, FFR, or QFR, does that strategy improve clinical outcomes? And that question is very important because you're going to increase the risk of the procedure by prolonging the procedure, giving more radiation, fluoroscopy, more contrast use, and using longer stents. Now, can that be justified? Yes, if it is proven in a randomized clinical trial that this strategy would provide net clinical benefit. I recently had the chance to review the results of FFR React trial. I cannot disclose them in this forum, but that will definitely help address this question. And then define GPS. We were actually the third center nationally to be invited to enroll patients. Unfortunately, that could not happen for a variety of reasons. That would also help answer some of those questions. So in 2022, this is a working document that several people in this field put together. I was fortunate to have contributed to this. So in 2022, how do we approach PCI? Once we have a successful result, you have to ask yourself which tool was used. Did we use a resting index? Did we use adenosine index? Did we use IFR or QFR? And we have different thresholds. So if thresholds are ideal, that means you have angiographically and a physiologically sound PCI result to stop. If it is suboptimal, then you have to do different maneuvers to figure out why it is suboptimal. It is related to a focal lesion, a focal stent related issue that can be further optimized, then all those steps must be taken. However, if it's related to diffuse disease or to factors that cannot be mechanically addressed, then there's no point in wasting time putting more stents and prolonging the procedure. Best medical therapy is the answer in those cases. So in conclusion, then, the use of physiology to determine the need for coronary intervention as well as to optimize the outcome of our intervention is really a step towards the 3 Ps of CAD therapy, i.e. personalization, precision, and ultimately perfection. And functional testing after intervention should be at the forefront as we gather more evidence in its use so we can continue to refine our treatment of CAD. Thank you.
Thank you, Abdul. Very elegant and very well put. Thank you for providing that information. So one question that I have for you, and this is a person who's not really done a lot of work in FFR, but I'm just extrapolating from my knowledge in echocardiography. In echocardiography, whenever we look into stenosis, there is something called as an effective orifice area versus a geometric orifice area. So could it be possible that when you tackle with the stent, the stenosis, you do look, it looks great geometrically, but maybe because of the curves and the way the tortuosity and other things, you could still have an effective orifice area in the coronary artery, which may be impaired. And perhaps that could account for a continued state of obstruction and slow flow. Although geometrically, it looks very elegantly done.
Yeah, I think you just summarized it very nicely. That is really the biggest limitation of the coronary angiogram. And one thing that the reason I started off with Grunzig's slide was the fact that PCI was established and approved based on a physiological concept and not an anatomic concept. You're right, we do not believe our angiograms, which is why we do FFR or we do IVUS, because we feel that it's very limited. Again, your concept of effective orifice area, we just do not understand. The angiogram is not a reliable tool in determining the accuracy or accurately predicting the effective orifice area of a coronary stenosis. But then once we're done with PCI, all of a sudden we want to believe our angiogram. So that is really the hypocrisy of of present-day interventional cardiologists. As far as IVUS is concerned, IVUS is great in optimizing your PCI result, but it tells you nothing about flow, because you're just going to IVUS a certain segment. You do not get the information of the entire vascular bed of what is really happening at the muscular level.
Great. And for those who may be wondering what is an effective orifice area, basically it means that even if the arteries the concept is even if the artery looks to be open up, but the flow on the side at certain point is very stagnant. So it creates almost like a bottlenecking phenomenon, and the flow only in the central area is faster than on the side. So that may be happening in the coronary arteries as well. So it looks like it's all open, but actually the blood doesn't move well on the sides or certain areas, and therefore there is a residual degree of burden of stenosis that is identified on FFR. Great work. Thank you very much, Abdul. And we have now Dr. Janet Kai. Dr. Kai is a first-year cardiology fellow, and Dr. Kai has developed a list of presentation of which will be very intriguing to see, something related to art and its relationship to cardiology. And I was looking through her profile. She did her residency at RWJ Medical School, and subsequently is staying with us, and she has been prolific with several of work even last year and this year, has been an avid presenter at the ACC, and so we'll look forward to hearing from you, Janet. What did you find interesting at ACC?
Sure, of course. Let me just share my screen here. Okay. All right, are we able to see everything okay?
Yes.
Lovely. All right, so good evening, everyone. My name is Janet. I'm a first-year cardiology fellow, as Dr. Sengupta had mentioned. There were many fascinating talks and topics covered at ACC this year, and one of the sessions that stood out to me was titled Art with Heart, Tales of Creativity in Cardiology. I was drawn to this particular session since music and art, they've been kind of a constant and meaningful part of my life ever since I was a child. So it was interesting to hear about how these overlap with our work in medicine. I look forward to sharing with you some of the interesting topics they touched upon during the session. So during my years in medical school, as well as in training, I've already met many physician musicians. Digging a little bit further into history, we can find many examples of such individuals. Dr. René Laennec, he was a flutist, a French physician who made his own flutes, actually, who later went on to invent the first stethoscope, which at the time was just a long hollow tube, as you can see in the picture. Dr. Alexander Borodin from Russia was a composer of several symphonies, operas, string quartets, including one of my personal favorite pieces. He played several instruments. He was a chemist as well as a physician who went on to help establish the first women's medical school in St. Petersburg. Dr. Edward Jenner, he's known for discovering the vaccine against smallpox. He was also an excellent violinist and flutist. So perhaps, the skills that we develop through musical training can also be applied to medicine, the ability to listen, to collaborate, empathize, and pay attention to detail. We then start to wonder about the connection between music and its potential impact on healing and the practice of medicine itself. During the session at ACC, they discussed a few small studies done by Dr. Dritsas at Onassis Cardiac Surgery Center in Athens, Greece. The studies included anywhere from 20 to 60 patients, and one was regarding the effect of music on anxiety and mood profile in cardiac patients undergoing exercise stress testing. The study showed that listening to music prior to exercise testing was associated with lower heart rates, as well as lower blood pressures during the recovery phase. He speculated that music can reduce stress, induce relaxation, leading to these results. Another study showed that music intervention immediately post-CABG led to decreased usage of meperidine and morphine, And finally, he examined the effects of music on pain and anxiety during electrophysiology procedures and found that anxiety scores for the group that was exposed to music were much lower than in the control group. So, it is known that a certain, autonomic or cardiovascular responses can be triggered or synchronized with music. Dr. Bernardi in Italy published a paper back in 2009 on the interactions between music and certain cardiovascular and cerebral measures, such as blood pressure, middle cerebral artery blood flow, respiration, and skin vasomotion. They used several famous pieces, including one titled Nessun Dorma, an aria by Puccini, which is more of an emotional and lyrical piece. There were about 24 individuals involved in the study, and they, also used a couple studies that were a little bit calmer. I would say this piece is, a little bit more lyrical, as we said, a little more of that sort of ebb and flow. And so the first line that we see kind of in this particular diagram is what they call a music envelope. Essentially, it is a music profile that's proportional to the amplitude of the audio signal throughout the piece. So you can kind of see the lulls and the peaks throughout the music itself. I'm going to try and see if we can actually share a small clip from it and then maybe point out kind of where it lines up. And so, this segment kind of represents the moment of sort of peak intensity throughout the entire piece itself, which is, about like 3.5 minutes long. And it kind of correlates to the segment here about 3/4 of the way through. And you can kind of see the peak here representing, that the moment in the music. And then we also note that there's synchronous sort of a rise in like heart rate, increases in blood pressure, as well as cerebral blood flow activity and velocity, and skin vasoconstriction as well after that sort of lyrical crescendo, so to speak. The study concluded that vocal and orchestral crescendos produced significant correlations, p-value of 0.05 or less, between cardiovascular and respiratory signals and music profile, particularly with like blood pressures and skin vasoconstriction. The changes were, they found, proportional to crescendo, in contrast to pieces that were a little bit calmer and kind of more uniform throughout, fewer swells in the music, that induced skin vasodilation instead and reduction in blood pressures. And so the findings suggested by the small studies done at Onassis have also been seen in a couple of meta-analyses on the subject. This particular meta-analysis was published in December of 2020 in the Annals of Surgery, and it was titled The Effect of Perioperative Music on Medication Requirements and Hospital Length of Stay. It included about 55 studies and sampled nearly 5,000 patients, and results showed that perioperative music therapy reduced postoperative opioid requirement with a pooled standardized mean difference of 0.31, a p-value of less than 0.001, indicating its significance. Standardized mean difference is a summary statistic used in meta-analyses when studies don't use the exact same outcome measure. And expresses the size more of the intervention effect in each study and not necessarily an absolute difference. So, roughly a mean difference of 0.2 is potentially considered small, 0.5 is a moderate effect, 0.8 indicating a large effect size. And perioperative music also significantly reduced intraoperative propofol requirement with a pool standardized mean difference of negative 0.72 and Versed requirements with a mean difference of negative 1. And there's no significant reduction in the length of stay based on their study. So in conclusion, perioperative music can reduce postoperative opioid and intraoperative sedative medication requirements. And so another meta-analysis that was published in Open Heart last year by a group of surgeons in the Netherlands showed that music intervention relieved anxiety and pain in adults undergoing cardiac surgery. There are 16 studies involved in this particular meta-analysis. Primary outcomes were post-operative anxiety and pain that were graded on, several different scales. They ultimately had to calculate a standardized mean difference score as well. Patients were found to have reduced anxiety even after just one post-operative music session. Reduced anxiety with daily music intervention was noted for up to 8 days post-operatively. The largest beneficial effect on anxiety was seen when patients selected music from sort of predetermined lists, followed by self-chosen music. And they concluded that music intervention post-operatively were associated with reduction in anxiety and pain in the cardiac surgical population. Of note, Dr. Dritsas, in one of his past presentations, had also suggested that cardiac patients may benefit most from more relaxing music. Tempos may be more in the andante or adagio ranges, ranging around 60 to 80 beats per minute, with a certain level of what he called progressive change to maintain some prospect of non-familiarity. He suggested considering classical music of Mozart, Vivaldi, Bach as ideal for the Central European population, but did mention to correct for cultural aspects, as classical music may not be as deeply embedded or embraced perhaps in other parts of the world. And finally, taking a look outside of cardiology, there was a study done in Finland and published in Brain back in 2008 that showed listening to music enhances cognitive recovery and mood after strokes. Listening to music activates a widespread network of brain regions relating to attention, memory, motor function, and emotional processing. This particular study included 60 patients with a middle cerebral artery stroke, and they were randomly assigned to one of 3 branches. One was music therapy, one was language therapy, and the third one was a control group. There were 54 patients who completed the study ultimately. So during the 2 months after the stroke, patients were instructed to listen daily to self-selected music in the music therapy group, audiobooks in the language group, while the control group received no listening material. And patients underwent neuropsychological assessment, as well as questionnaires regarding mood and quality of life at various times after the stroke, at 1 week, 3 months, and 6 months. And it was found that recovery of verbal memory and focused attention improved more in the music group compared to the other groups. And individuals in the music group also experienced less depression and confusion compared to the control group. And so really just to summarize, music can trigger a lot of changes in blood pressure, heart rate, cerebral blood flow, et cetera. Perioperative music can reduce post-operative opioid as well as intraoperative sedative medication requirements. Music interventions post-operatively were associated with reduction in anxiety and pain in the cardiac surgical population. And in stroke patients, more improvement was noted in recovery of verbal memory and focused attention with music therapy than verbal therapy or neither treatment. And as music therapy comes with little to no risk or side effects, it's certainly worth considering in augmenting the care of our patients. Though it can be sometimes difficult, I think, to quantify the result, we do seem to have some evidence to support this connection between music and healing. And that's all I have. Thank you very much for your attention.
Thank you very much, Janet, for this presentation. And, it's interesting. So, I have just had one personal anecdote to share, and that is I've used music during TEE. And what I've realized is that typically my sedation requirement has gone down. They fall asleep faster. And second thing is when they wake up, they only remember the music, because when I started the music, asked them to play the music on or something, they just remember that and going into sleep. And so that's one thing which we have found. And there are many other operators in the cath labs or surgical labs, they like to use music, but this is not a uniform experience. Some other people find music more distracting. So I think it's also the kind of the music that you use that is important. But music also helps to bring more calmness with people, particularly in team events. So this is something I'm an avid advocate of. There are 2 aspects that really is disruptive in the hospital, and one thing is the beeping of all the gadgets and the distracting noises, which is not well tolerated by patients. And second thing, of course, is the light, the amount of light exposure, and therefore delirium and all those things is a common occurrence. So your work that you presented is an interesting paradox to what Dr. Moreira presented. When noise increases the risk of cardiovascular diseases, but music could probably more stress relieving depending upon the type of the music. So I think you bring this presentation to closure by we started from noise and we end with music. So I find it intriguing and interesting that our presentations lined up in that same way. But anyway, so I do not personally have any specific questions, but any other person wants to contribute to the discussion, please feel free to write in the chat box. But in the meanwhile, Janet, so how do I felt like you personally like music. So how do you use during your fellowship, or what do you do? Do you ever move towards the music zone during your very stressful fellowship? Is that a way you could relieve your stress during your fellowship? I'm just asking.
Yeah, definitely. I think, you know, and so back in, at least in medical school, we at least did have smaller ensembles. You know, there was like a music oriented group. And I think, you know, even then it was definitely a good source of stress relief. I think that population obviously becomes a little smaller with each step in training as our kind of group becomes smaller as well. But, you know, I have like a little keyboard that I kind of keep, and it's always been, I think, a good outlet and source of stress relief 100% for myself. And so I think it's interesting to see that that does reflect for our patient population as well. And I was actually talking with Andrew, one of our other fellows, like earlier in the year when he came in, you know, noting that he found like a recent article somewhere that had said that there are certain alarms that are meant to be discordant, you know, like that code blue alarm that's supposed to be irritating when you listen to it because it's supposed to catch your attention and kind of make you feel kind of uneasy, right? So you need to address it. And so, you know, that was another interesting thing that's kind of purposely, I think, woven into medicine and kind of medical care.
Yeah, so thanks. But when you're mentioning about the music, I also want to emphasize to the entire work group and everybody here that burnout is a typical problem right now we are seeing in cardiology. So whatever is your method of relaxing, be it music, be it mindful meditation, be it deep breathing, please practice it, because but there will be times and days when you will want some of these things to help you, because it is very stressful, and burnout is a big problem post-pandemic. It's surging very high with the volumes and everything else. So taking care of yourself is very important, and certainly if you can gravitate to something that you enjoy with is very important. As much as you want to have your work-life balance and everything else, sometimes it's difficult. So finding your methods to be able to relax and unwind is very important as well. So hopefully we will have a certain degree of balance in our lives. Thank you, everyone. Yes.
Sorry, just one last question. So it seems like most of the music they're referring to is just kind of like instrumental, classical, like slow music, right? Not the stuff like Ahi listens to in the Echo Lab, the loud noisy, right?
Yeah, I think there is so it was hard to generalize because amongst like the 55 studies that were involved, there were some that picked, you know, pre-selected list of like classical pieces. And there were others that would include some like, you know, like smooth jazz, like a little like other stuff that was maybe a little bit, you know, a little more modern. A little bit
noisy ones, I agree with Dr. Sengupta. They might do what Dr. Moreira was telling us about last week.
So Sabah is adding a little bit of fun and well, I think we'll leave that for people to decide what music inspires them and what relaxes them. Yes. So Ahi is talking about Pearl Jam. All right, I think it's time for taking break.
Don't include rock and roll.
Unwind ourselves.
Okay.
Take care. All right.
Thank
Good
you.
evening.